mas pode abrir o microfone e fazer alguma pergunta. Eu queria já registrar a presença do Dr. Jorge Davila.
Hey, good afternoon. How are you?
Fine. Are you fine, friend?
Thank you. Yes, I'm very well. Thank you, Pablo. Let me see. Can you see me?
Yes.
Me va a perdonar, mi portugués es no bueno todavía. Algún día.
Thank you to join us. Thank you. Thank you so much.
Thank you for the invitation.
Bom, pessoal, se não tiver nenhuma pergunta para a Gisele, fica à vontade se quiser acompanhar a aula do Dr. Jorge, tá? Será um prazer você estar aqui com a gente. George, I make you the host now, okay? I make you host now. You can share your screen.
Are you able to see my screen?
Yes, very good.
Perfect. Let me see. Do you see two screens or only one?
Yes.
One or two?
One, just one.
Okay.
Very good.
Perfect. So how long time do I have for this presentation? That's a question that I didn't ask.
Feel free to begin, Professor.
Okay, perfect. Thank you for the invitation. I'm going to speak a little bit of non-conventional MRI in the assessment of pediatric brain tumors. And what I'm going to do is I'm going to share a few cases from my practice and see what went well and what went wrong. So the objective of these presentations are first to be familiar with the use of non-conventional imaging in the assessment of pediatric brain tumors, and also to recognize the main technical factors and artifacts that can affect proper assessment of these sequences in the value of the most frequent intracranial tumors. So it's going to be a case-based presentation, and I hope we can learn some important points here. And I always ask this question to my residents and fellows. I show them these three images and I ask them if they can tell me which one of these is an embryonal tumor. And of course they go and they say C is embryonal tumor. Some say no, B is embryonal tumor, but they never say A, because I think it's not a traditional medulloblastoma that is in the midline. So, but I always tell them that the most important sequence for detecting embryonal tumors is diffusion. And in diffusion, you have to see the ADC values, and the ADC values usually are decreased or are diminished in patients that have in embryonal brain tumors. So let me see if I can have here my pointer. Do you see my pointer? Okay, so here you have the tumor that is in the left, in the area of the left foramen of Lunska that has diffusion restriction. Here you have a tumor that has intermediate diffusion of values of ADC, and here you have an increased ADC value. So this was an astrocytoma on the right side and ependymoma in the center, and this was the embryonal tumor that was a typical teratoid rhabdoid tumor with very low values of ADC. So I think diffusion is a very important tool because that is going to help us to identify the cellularity of the tumor. And the higher the cellularity, the higher the grade of the tumor most of the time. And also you are going to have and decrease ADC value. So it's inversely proportional to the ADC value and the degree of the grade of the tumor. Remember that the embryonal tumors that are usually present diffusion restriction, in general, all of them present diffusion restriction, and they are the medulloblastoma, that teratoid rhabdoid tumor, the embryonal tumor with multi-layer rosettes, and the metastasis. Other tumors that can also give you a decreased ADC value are the pineoblastomas and the malignant germ cell tumors. And in all of these cases, when you are looking for metastasis, you have to look in the diffusion images because the metastasis can be hidden there. If you have low-grade tumors like the NET, you're going to have high ADC values. So you're not going to have diffusion restriction, you are going to have facilitated diffusion. And you can have also pitfalls that are related to hemorrhage calcification, and especially in the posterior fossa or in the temporal regions because of the thick bones, you can have also artifacts related to that. So here you have 3 different patients that have different tumors in different areas of the brain, and all of them show diffusion restriction, and all of them were embryonal tumors. The first one was a teratoid rhabdoid tumor, atypical tumor, and the second was a classic medulloblastoma in the midline, possible category 3. And here you have the embryonal tumor with multi-layer rosettes in the supratentorial region. Other sequence that helps us a lot in the assessment of tumors is MRI spectroscopy. It's classically that you will see the high peaks of choline related to the high level of membrane proliferation. You have a decreased NAA and choline due to the edema necrosis, and you can have lactates and lipids due to the presence of necrosis within the tumor. So this is the classic presentation for malignant tumors. And this is an example of a low-grade tumor where you have some choline and creatinine that is not so high. It's a little bit more noisy, and you have a preserved NAA. While here you have an astrocytoma grade 3 with high peaks of choline, and you have lactate as well, and NAA, it has disappeared. So this is the classic appearance of tumors in adults, but in pediatrics, you have to be careful because you can have tumors that have the same configuration with high choline, creatinine, and high choline NAA, but also you're going to have benign tumors like benign polycytic astrocytoma that can have the same characteristics with high peaks of lactate, high choline, and decreased NAA, and you can be confused, and this can be confused with a high-grade tumor, especially because these tumors tend to have lots of enhancement as well, and that's another pitfall. And other important factor that you have to remember is try to recognize the tau molecule of tau at 3.44 that is traditionally seen in embryonal tumors. So this is a classic case of a pilocytic astrocytoma where you see a high peak of choline, and the NAA is diminished, but it's not completely disappeared. And this is a patient that had a pilocytic astrocytoma. This is a patient with a medulloblastoma, and here you can have the taurine peak, same as in this other present publication that was taken from the literature showing the taurine molecule. Now let's go to speak about perfusion. And in perfusion, we have 2 methods that are that use contrast, and we have ASL that do not use contrast or uses an endogenous contrast. The ones that use contrast, we have the T2 star images and T1. And the first one, what we're going to do is, this is the dynamic susceptibility enhancement. So what we're trying here is we're trying to see the changes of susceptibility as we are giving contrast to the individual, and we're going to see the decrease of the signal intensity in the tissues of the brain with a late recovery. While in the dynamic contrast enhancement, what these use T1 sequences, and what we are seeing here is the progressive enhancement of the tissues that are affected within the tumor. But what really we're looking is for the areas that are enhancing, and these areas that are enhancing represent the areas that have a break in the blood-brain barrier. So both of these perfusion sequences, they show different, they show different information. One of them is giving you information related to the degree of enhancement of the tissue, how much the enhancement the tissue gets due to normal blood, while the second one is telling you how much of the blood-brain barrier is damaged. And when you are assessing the dynamic susceptibility enhancement method, you have to correct this blood-brain barrier. Otherwise, you're going to have serious problems when you're analyzing your data. And the other, and that the type of sequence that do not use contrast or has or uses the endogenous contrast agent is ASL, and most of the available commercial sequences just give the information about relative cerebral blood flow instead of that cerebral blood volume that is the one that we need to assess for the degree of perfusion tumors that we are going to see later. So remember that the tumors are not entities that are homogeneous. They usually are heterogeneous. The higher degree of the tumor, the higher the heterogeneity. So you can have in one tumor areas that have this degree of enhancement on T2, and you can see how is the degree of enhancement within the tissue. But you have also areas where you have the blood-brain barrier. And usually in the high-grade tumors, you have both of them. And if you want to analyze the diffusion susceptibility enhancement, you need to correct this area of enhancing, or this area of a blood-brain barrier break. So here you have, and what is important to remember is also both of the methods are going to show you, are going to depend where you place the region of interest. Because as I mentioned earlier, the tumors are so heterogeneous, you are going to have areas that have already necrosis within the tumor, but also you are going to have areas that have high grade. So it's very important to know where you are placing the region of interest. And be careful with the susceptibility artifacts that especially happen in the temporal bones and posterior fossa, because that's not going to allow you appropriate assessment of the region of interest because of the artifacts. So when do I use perfusion? I use perfusion when I want to grade gliomas, when I want to guide, I want to make a stereotactic biopsy to see which is the area that has higher possibility of grade. Also for guided radiotherapy, to monitor response to the therapy, if you want to assess for radiation necrosis or for recurrence. So this is an example that I took from the literature. This was already published in 2006, many years ago, 15 years ago. And you can see this astrocytoma grade 3, you have a very large heterogeneous mass with peripheral enhancement, and you have the areas of increased relative blood volume in the periphery of the tumor. And this is a different tumor that has an area of diffusion restriction that is telling you, speaking about the high cellularity within the tumor, has the abnormal enhancement. In that portion of the tumor, you have an area of necrosis or cystic changes as well there, high peak of choline, and NA has almost disappeared. And here you have the increased relative cerebral volume in the same area where you have the diffusion restriction, and this was a high-grade astrocytoma. What we do in dynamic contrast enhancement is we see how fast is the enhancement of the tumor, and usually tumors that have high-grade tumors or patients in which we see progression, you're going to see that enhancement is going to be around the 30 seconds. It's very fast. While if you see a very slow enhancement, that's going to represent necrosis or scarring. And in these cases, you can wait until 2 or 3 minutes and you are going to see a little bit of enhancement at that point. So that's how we can differentiate a tumor that is a progression disease or a tumor that is still growing from an area of necrosis or scarring. So this is a different patient where you can see an expansile lesion, cystic component predominantly of high T1 signal intensity 21, and the periphery has diffusion restriction with low ADC values that they are speaking about the high cellularity of the tumor. Choline tells you that there is a high choline. DNA is not so low in this, at this point, and this is anterior to the tumor. This is in the contralateral side to compare the how was the normal spectrum in the contralateral side. And this is the perfusion. The red one is the one done in the normal side, and the red yellow one is the one that has been done in the affected side by the tumor in the solid portion. So what we measure here, we measure the area over the curve, and this is going to give you the relatives. This is going to be give you the cerebral volume, and this is the relative cerebral volume because we have to compare these two curves to be able to see if there is an increase relative cerebral blood volume or no, and you can see that it's quite increased in this side, so you can, and that's given by the area over the curve. And this was a patient with diagnosis of glioblastoma, classic cases. So when do we use, when we should use the non-conventional imaging? If we want to characterize the tumor and the diagnosis, both and the tractography is used especially for during surgical planning, try to do a maximal resection, and because that is going to give a better prognosis. Remember that the mere this tumor that is removed, the better the prognosis for these patients. Diffusion and the tractography can give you early signs of recurrence or progression. Perfusion and spectroscopy are important because that's going to help you to differentiate radionecrosis from pseudoprogression, or that is could be the same, and also can give you a progression of disease. This is the same patient that was operated, and this is the post-surgical MRI, and you can see 2 months later the patient has a new lesion in the right thalamus. The spectroscopy in that area shows a high peak of choline, low NAA, and so that was a thalamic recurrence. This is a different patient. You can see that the cortex is quite thin. The signal intensity in the right superior frontal gyrus is very high, close to the CSF signal intensity. No enhancement. Choline is slightly higher than NAA. And this is diffusion where you see increased ADC values. And when we did the dynamic susceptibility enhancement, you can see that the value within the tumor is much smaller, or the area of the tumor was much smaller than the contralateral side. So here we are speaking about a low-grade tumor. And when we did dynamic contrast enhancement, there was no difference between the normal tissue and the abnormal tissue in the same side. So the curves were quite similar. So this was this is showing you that there is no break of the blood-brain barrier, and there was not too much enhancement of the effects of susceptibility effects of gadolinium within the white matter. So that was a low-grade glioma. This is a different patient. This is a patient that presented with a pontine glioma, and the patient was the patient had radiotherapy, and when you with some areas of enhancement. So when we were here, we did the spectroscopy, and you see that the peaks of lipids were very high, choline was high, and DNA was very low. And this is the perfusion that we did through the mass. So number 2 represents the normal cerebellar tissue, and this is the curve, which is larger than the other 2 curves. In green is in the solid portion of the mass, and you can see that the volume is smaller than the volume that was done on the normal tissue. And here, this is the area of cystic changes in the center of the necrosis, where you can see that the curve is quite plain. So this was a patient with radiation necrosis. This is only to show you how we have to make the post-processing. When we are trying to do where is the starting point and where is the end point, you have to be careful where we are placing those lines, because this is wrong. When you are trying to do the post-processing of perfusion, you have to start where the curve decreases, and this line should be at this level where the curve recovers. Otherwise, you are going to have wrong lectures of the perfusion. So be careful when you're doing the post-processing. And this is 1 year later, where all the areas of necrosis have decreased. And here you have more lactate, and you don't have choline or NAA, in keeping with radiation necrosis. Okay, we did speak about this already. And how we can differentiate radionecrosis from tumors. In radionecrosis, in perfusion, we're going to see a decrease or low relative cerebral blood volume, and also you're going to have a very slow enhancement of DCE. If you have a recurrent tumor, you're going to have high relative cerebral blood volume, and you're going to have a rapid enhancement around 30 seconds on T1. In radionecrosis, you're going to have lactate lips, and you tend to see not choline. While if you have a recurrent tumor, you're going to have high levels of choline versus NAA. And PET is going to help as well. You are going to have a very low metabolism in radionecrosis, while in recurrent tumor, you're going to have a high metabolism. This is a different patient. It's a patient that has, it's a 2-year-old patient that presented with this tumor in the right frontal lobe, cystic areas with areas of intermediate signal intensity onto these focal nodular areas that were intermediate, they were enhancing. They had diffusion restriction of these areas. And in the perfusion, you can see that those areas have an increased relative cerebral volume. In this case was 170% when compared to the contralateral side. And you have multiple other areas, some of them closing to the 200%. And this one that is 90 is here anterior to the mass. So this was anaplastic ependymoma. That was the diagnosis. This is a different patient. This is a girl with a glioblastoma. This is the initial MRI. You see a lesion, it's a horrible lesion, very heterogeneous, with some hypointense areas in the periphery, lots of edema. Post-contrast has a very heterogeneous enhancement, with areas do not enhance in the center. This is a flare, and you see these areas of high signal intensity on T2 flare in the periphery. This was post-contrast, and also this is the B1000 that doesn't show too much diffusion restriction there. So this is the post-surgical imaging 42 hours, less than 42 hours later. And this is the imaging 2 months later. And here you have a new area of enhancement, and you can see that the perfusion is the relative cerebral volume. It's increased in this area. However, when we made the numbers, you can see that it says 100% versus 69%. Now, what happened here is that we made a mistake placing the ROIs, the region of interest. In this case, the region of interest that has to be compared with a normal tissue should be 2 versus 3. And this is the comparison of 3 versus 2. That's why here you have 100%, and looks like it's the ADC, the percentage have been diminished. So you have to be careful with that. In reality, what you have is, this should be like around 150 to 170%, okay? And you have high choline, NA is disappear, and you have high peaks of lipids as well in this progression of disease. This is a different patient that has a tumor with very heterogeneous hemorrhages within the tumor, that has edema around, pathogenic edema around the tumor, this displacement of the midline. Again, T1, high T1 signal intensity of that area, like some areas of high signal intensity with some hemorrhagic changes, peripheral enhancement. And this is the ABC map. And this area, if we go back, this area, it represents more changes related to the susceptibility artifacts from the hemorrhage. So that's something that we cannot assess properly. When you have bleeding within the tumor, it's very difficult to make a diagnosis of that area. This is the map, the perfusion map, where you can see in the periphery, increased relative cerebral volume, that is 214, 259 in comparison to the contralateral side. So this is another patient that had a high-grade tumor, and this is the noisy spectroscopy where you see high peaks of lipids, and here you have everything else is noisy. It was a glioblastoma. That's a different patient that has a lesion with a very large cystic component and solid component in the periphery that is enhancing. That component also has diffusion restriction, and this was a grade 3 ependymoma. This is 8 hours post-surgery. They removed the tumor, and then there was a little bit of enhancement in the periphery. And when we did the perfusion imaging, we saw that maybe it was very close, but the values were very close. And so this is the spectroscopy that shows high choline and low NAA in the periphery of that area. And this is 1 month later, and you see that this area is thicker, the area of enhancing is thicker, and now you have a high peaks of choline, higher than before. And here you can see that here still you have some NAA within some areas of the tumor, but now you have very high peaks of choline. The NAA is almost gone. That is telling you that there is some progression of the tumor. And these are this is the perfusion map where you see again high values of relative cerebral volume all around the tumor. And 2 months later, this was even getting higher or growing. And so the patient, even you have diffusion restriction now around the tumor, and this was a recurrence. Again, still very high values of relative cerebral volume. So the patient went for a second surgery plus a radiotherapy 6 months later. And here you see in the periphery that the relative, again, here there was another mistake as well. You can see here that it says 124 and number 2, but number 2 is the normal tissue. So we should be comparing number 3 against number 2. So in reality, the relative cerebral volume was diminished, was around 80%. So, and there was no increased relative cerebral volume around the tumor. So this was more radionecrosis. And this is the spectroscopy that shows you some only lipid peaks in keeping with radionecrosis. And this is a different patient. This is a patient that has a posterior fossa was operated from a posterior fossa ependymoma years earlier. And this is the regular follow-up where you see a little bit of residual tissue here in the left, at the level of the left foramen of Luschka and the cerebropontine region. 1 year later, so 9 years after diagnosis, the patient has a new area of abnormal signal intensity here in the right cerebral peduncle. Spectroscopy didn't help too much. And we did this perfusion at that time, where you can see that the region of interest is telling us that the relative cerebral volume is markedly diminished. And this is 3 months later. And the lesion did grow a lot. You have decreased some NAA, but no more other data at that time. We did again the perfusion at this time, and again here you have 2 versus 3, and now you again see that the relative cerebral volume is diminished here, but there was a problem here. All these curves were very noisy. So these are curves that are non-diagnostic, and you should be careful with them. So before doing perfusion, what you have to do is you have to value how are the curves. And if you see curves like this one, they have too much noise and they are not of clinical value. So 3 days later, we did again a new MRI. We did repeat the perfusion. And in here, you have an increased relative cerebral volume, and you have a much better curve here that is of diagnostic value. So you can see the difference between these two curves. So, and this is the spectroscopy with lots of artifacts, and you have already some lactate peaks here 4 months later, And again, the relative cerebral volume keeps going up. Now was 193, and the tumor was growing. So this was an anaplastic astrocytoma, and this was after radiotherapy, and you can see that the peaks of lipids did grow a lot within the area of the tumor that was related to radionecrosis. However, the patient had all these metastases supratentorially that had also increased relative cerebral volume that were around 233 and 373. So that was telling us that the patient had a very progression of disease with metastasis. This is a different patient that has presented with this hemorrhagic mass within the cerebellum in the posterior fossa. The MRI where we see the area of bleeding within the tumor, and these are the ADC values around the tumor, and you can see that they have increased ADC values that goes with low-grade glioma. And these are the part of the tumor cystic changes. So this was a low-grade glioma, and you can see that was a hemorrhagic phalomyxoid astrocytoma, and the ADC values were diminished. So if you can see in the periphery, if you can value in the periphery the ADC maps, that's okay. If there is too much hemorrhage and artifacts, be careful with that. This is a different patient, a 16-year-old that presents with headaches and ataxia, a large tumor in the midline with areas of enhancement. If you don't have the enhancement, you can say, okay, this is a classic midline pontine glioma, but the fact that the patient is having enhancement, that it doesn't go with a classic pontine glioma. The patient has some diffusion restriction in that central part that was also with pontine glioma, the high peak of choline, no NA presence, and here you have the perfusion that shows very high values of relative cerebral volume that were going around 268, 230, etc., very high values. So this was a diffuse midline glioma. And this is a different patient that presents with worsening intention tremor, and you have a well-defined mass with a heterogeneous enhancement, ISO signal or signal intensity on T2, has an exophytic component going within the middle fossa in the right side, heterogeneous enhancement within the center with some areas of necrosis in the center. So the spectroscopy showed high peaks of choline with respect to NA8, and you have lactate as well. Doesn't help because low-grade gliomas can have the same. And this is the relative cerebral volume showing decreased values on the map, and so the relative cerebral volume was diminished, and this was a low-grade glioma. So what I have to remember from this presentation is that advanced imaging is complementary to conventional imaging, that low ADC values go with embryonic tumors, and high ADC values go with low-grade gliomas usually, or the NETs, for example. And high choline NA peaks can be seen in high-grade tumors, but remember that low-grade glioastrocytomas in pediatrics can present in the same, can have the same presentation. And something that I recommend is try to do non-conventional imaging as part of routine rather than only trying to use when you have issues, because if you use only these kind of techniques when you are not when you need it, you may not be able to do a proper assessment because you don't have the routine of doing this post-processing, because there can be many pitfalls, starting from how you do the place, the region of interest, to where you start the curve, where you end the curve, etc. And I hope you, and thank you very much. That was the end of my presentation. If you have some questions, I'm open to answer them.
Amazing, amazing lecture, dear George.
Thank you very much, Pablo.
Thank you very much. We have a question in the chat. And Dr. Bernardo Martins from Brasília, Brazil.
So we have, I read the question. So I think it's important to try to diminish the flow artifacts on the spine when we are assessing for metastasis. And yes, Vive helps a lot. The 3D sequences help a lot, more than the 2D. And something that people is asking or suggesting is doing 3D steady state imaging, like 3D Fiesta or 3D CIS or 3D TrueFIS, because what we want to do is we want to decrease the number of flow artifacts, and that's going to help us to detect the nodularity in metastasis. So by sure, if you are able to do 3D images on the spine, that's going to help a lot.
Thank you, Dr. Bernardo, for a question. One more question for Dr. Jorge Davila, please. Write the chat. How's the weather? How's the weather?
How is the weather? That's a very good question. We are closing the zeros.
Oh.
So we are going to start having negatives maybe in 1 or 2 weeks.
How about the COVID?
We are very safe here. Around 90 to 95% of the population in Ottawa is already vaccinated.
Very good, very good.
So we don't have many, and they are going to start giving the 3rd doses for the vaccine now. So I think in next week or 2 weeks, they are going to start having that. So, and yeah, and then in the hospitals we are obliged to have the vaccine. Otherwise, you are not able to work.
Thank you, Dr. Jorge Davila. Thank you to join us tonight, Neuro Club, November 2021. Very nice lecture, amazing case.
Thank you very much, Pablo. Thank you for the invitation, and I hope we can be better.
Have a good night. Have a good week.
You as well. Take care.
See you next meeting, friend. Thank you very much.
I will see you there. Take care. Bye now.